Namaskar दोस्तों, good evening friends. I am Dr. Sanjay Kalra, your friendly and familiar endocrinologist, and you are watching Dr. KK Medtalks, Obesity Talks with Dr. Sanjay Kalra. आज के हमारे नॉन स्टॉप शो का 1074वां 1074th एपिसोड है. Let's have the headlines for today. Now, eating at odd hours increases the risk of obesity, says research. But ये तो हमें पहले ही पता था. अगर आप पूरा दिन खाते रहेंगे, कुछ ना कुछ चबाते रहेंगे, तो वेट बढ़ सकता है. At the same time, small frequent meals are a treatment for obesity. तो देखते हैं क्या सही है और क्या गलत है और कैसे है. Experts say that high body mass and obesity can lead to mental health disturbance such as depression, especially in women. तो मोटापे से डिप्रेशन हो सकता है. Children born to mothers with obesity, both before and during pregnancy, मतलब किसी महिला को, किसी खातून को प्रेगनेंसी से पहले मोटापा है या प्रेगनेंसी के दौरान, गर्भपात के दौरान उनका वजन बढ़ता है, इनके बच्चों को such children have an increased risk of neuropsychiatric and behavioral conditions including autism. इसे कहते हैं transgenerational disease. And a pilot study has shown that ketogenic diet, keto diet जो है, it can help in managing severe mental illness and seizure disorders. Research has also shown that intermittent fasting, if done under medical supervision, can improve not only weight but also heart health. अब इतनी सारी चीजें इकट्ठी हैं, साइकोलॉजी, डाइट, वजन. सो लेट्स गो टू आवर टॉपिक फॉर टुडे. आज का टॉपिक देखते हैं क्या है. ओ बाप रे, सच अ हेवीवेट टॉपिक. ओबेसिटी वैसे ही एक हेवीवेट डिजीज है. जो उसके साथ जीते हैं उनसे पूछें. सो ओबेसिटी एज अ साइकोसोमैटिक सिंड्रोम. So we need to learn, of course, we need to remind ourselves what obesity is, and then we need to learn what psychosomatic syndrome is, and then how we can help manage this. We need an expert for this. And for me, it's a matter of great pleasure, great pride, great happiness for the entire country, actually, to be able to introduce once again Dr. Sarthak Kukreja. Warm welcome, Dr. Sarthak.
Thank you, sir.
Dr. Sarthak is a medical officer at the Department of Psychiatry in AIIMS New Delhi, and with degrees from prestigious colleges such as AIIMS Rishikesh and AIIMS New Delhi under his belt, he is now going to join DM in psychosomatic medicine. And God willing, in 3 years, he'll become the first certified, the first qualified psychosomatic medicine specialist of our country. So warm welcome, Dr. Sarthak.
Thank you so much.
Dr. Sarthak has been with us earlier also on Obesity Talks. And Dr. Sarthak, आपको ग्रीटिंग्स आ रही हैं राम जी अग्रवाल साहब से, हंसा परमार जी से, विमला कपूर मैडम, मैडम स्वप्ना जैन वेलोर तमिलनाडु से, उजैर अनवर साहब आपको गुड इवनिंग कर रहे हैं. एंड हाई टू यू फ्रॉम डॉक्टर योगेश उपलेंचवर. Today is a special day. It's Lodi, Sankranti and Pongal. Such a happy festival. जब हम festivals की बात करते हैं, Dr. Sarthak, so do festivals make us happy or can festivals make us sick as well?
The purpose of festivals is to make us happy, but at times, we can get overwhelmed with all the work that needs to be done to celebrate the festival. So sometimes, it depends on what stage you are in your life.
Yeah. So everything that way is a double-edged sword. On festivals, you want to be happy, but you are exposed to many health hazards. For example, you have to work a lot to keep the home clean. You go out for to a public gathering जहाँ पे festival celebrate किया जा रहा है. You might get injured, you might get in trouble. खाना पीना बदल जाता है. You might overeat. Some people may get food poisoning. So all these things do occur on festivals. ऐसे ही जब हम बात करते हैं साइकोसोमैटिक हेल्थ की, तो साइकी और सोमा ये क्या चीजें हैं? डॉक्टर सार्थक विल एक्सप्लेन टू अस. एंड ये जो साइकी एंड सोमा है, दे आर एक्चुअली मेंट टू बी टूल्स एंड टारगेट्स, बोथ टूल्स एंड टारगेट्स फॉर होम्योस्टेसिस. होम्योस्टेसिस क्या होता है, डॉक्टर सार्थक से पूछेंगे. साइकी के साथ हम टारगेट क्या लेके चल रहे हैं? खुशी, हैप्पीनेस, वेलबीइंग. और टूल कैसे है? हाउ कैन वी यूज आवर साइकोलॉजी टू अचीव दैट टारगेट? सिमिलरली हमारी बॉडी एक टारगेट भी है कि हम चाहते हैं कि हमारी सेहत तंदुरुस्त रहे, हम तंदुरुस्त रहें, हमारा शरीर तंदुरुस्त रहे. And we can also use our body as a tool towards achieving that health. Maybe I go and exercise, I take care of myself. तो अब इतना सारा कुछ कॉम्प्लिकेट हो रहा है डॉक्टर सार्थक, बट द नेशन वांट्स टू नो व्हाट डज साइकोसोमैटिक मीन बिफोर यू कैरी ऑन विद योर प्रेजेंटेशन.
So, sir, to put it in simple words, psychosomatic, it means the connection between the mind and body. It does not necessarily mean how the body is affecting the mind or how the mind is affecting the body, but it uh, means how both of them are interacting and then resulting into something together.
So, perhaps if you have slides, you can share with us, and can we move further and see then if obesity is a psychosomatic syndrome? ये हमारा पहला question होगा. And if so, how can we use the principles of psychosomatic medicine to help prevent and manage obesity?
Sure. First, let's try to understand what obesity is. Obesity is a chronic and it's a complex disease which is defined by an excessive accumulation of body fat, which is usually measured using the body mass index. It significantly impacts health and is a major global health concerns nowadays. However, the understanding of obesity, it's not just about the numbers, and it goes beyond physical health. And because it has become such an important uh, global health concern, we need to look it from a different perspective, and not just as a collection of biological things happening, but to also include the psychological and the social influences that are going on. So, with that, I've already told what psychosomatic as a word it means. It emphasizes the interconnection between the mind and the body. It doesn't mean that one causes the other, but it rather emphasizes how psychological and physical factors they interact. So this relationship can either worsen or can improve a condition. Now, rather than I would say today, rather than just labeling obesity or any other illness as a psychosomatic syndrome, let's try to look at obesity from a psychosomatic perspective and try to fit it into a biopsychosocial model, which is a closely related thing, which, as the name suggests, that things are composed of biological, psychological, and social components. So, what happens when we look at obesity from a psychosomatic perspective and let's try and fit it into a biopsychosocial model? And then we'll subsequently see how this biopsychosocial model of understanding of an illness, how it can affect our understanding of disease as well as change our perspective when we are trying to manage such conditions. So, to look into the biopsychosocial model, first we'll go into the biological factors and look at the various biological factors which are involved in the in our appetite, which uh, and how they lead to obesity. So, we know that our body is it's remarkably good at keeping our weight stable over time, despite changes in how much we eat or how much we move. And this stability or homeostasis is managed by the body as a whole, mainly by the system in the brain called the hypothalamus, which acts as a control center, receiving signals from various parts of the body and managing our uh, body. So, what are these signals? These signals include hormonal signals and neural signals. Hormonal signals can include which can arise from the adipose tissue, that is the fat stores, in the form of leptin, or from the gut in the form of hormones like GLP-1 cholecystokinin, etc., as well as from the vagus nerve and the enteric nervous system, the nervous system which lines our gut. Apart from that, there is the role of insulin, the role of ghrelin, which actually tells us when we are hungry and increases the appetite. Then all these systems, like, they work together, and the whole system is mediated by the hypothalamic pathways. So for example, in a fed state, leptin will stimulate the brain neurons that reduce the appetite and increase. So leptin will stimulate the brain neurons that will reduce the appetite and increase energy use. At the same time, the leptin suppresses another set of neurons that normally increase appetite, so as to maintain a balance to keep the energy intake and expenditure in check. Now, this is how our appetite is regulated. Now, once we're eating, what happens to the energy? So, when we eat more than we burn, the extra energy, it gets stored in the form, it gets stored in our body as fat or triglycerides in the fat cells, which are called adipocytes. This fat, why as fat? So fat is an efficient way to store energy because it packs a lot of calories into a small space. However, when we are eating in excess, more than we are burning, so the fat stores in our body will keep on increasing, and then the fat will spill to other cells which are not meant to storage, and which will result in the harmful effects of obesity. Now, the research has also shown us that genetics play a very significant role in determining how likely someone is to gain weight. Studies have shown that up to 50 to 90% of the differences in body weight between people can be explained by genetic factors. And scientists have identified over 100 genes which are linked to obesity. And many of these genes, they influence the brain's ability to regulate appetite in various different ways. Such as genes can affect how much someone craves food, how easily they recognize when they are full, or their tendency to eat when they are emotional. Also, genetics also affects how people respond to environmental triggers. For example, some people are more likely to overeat when food is easily available to them, such as when they're at a party or there's a buffet, or sometimes people, they may turn to food as a way to cope with their stress. So all these factors are also determined by, to some extent, by genes. There are a whole lot of genetic syndromes which are directly related with obesity, or rather, I should say, there are genetic syndromes in which obesity is a central component. But if biology alone could explain obesity, then we'd expect that similar outcomes in everyone with the same genetic makeup or hormonal profile. So it's not just the genetic factors, there needs to be something from the outside that is helping or that is causing us to gain weight. So, uh, this external factor or the environment in which we are a part of has now been referred to as an obesogenic environment. And as our environment is becoming more obesogenic, that is the ease that is it is very easy for us to access high calorie foods nowadays, and we have a lot of options to reduce our physical activity. And both these, when present with a strong genetic risk, they people are more likely to gain weight then. So we've uh, we've gone through the genetic factors, we've gone through the biology of appetite and hunger in brief. We've seen how environmental factors are acting, but again, These are not enough. Apart from the uh, biological factors and environmental factors, there are psychological factors that are playing a very important role, especially in obesity. These psychological factors include things like stress. Now, stress, everyone experiences stress on a daily basis in today's world. And chronic stress is a major psychological factor contributing to weight gain. And it affects our bodies and behaviors in multiple ways. For example, when someone is under constant stress, whether due to financial issue, family problems, or mental health struggles, the body's response system stays activated for extended periods. And this ongoing activation, it has two effects. It can have a direct effect, it can have an indirect effect. Uh, the direct effect includes the stress hormones like cortisol that can themselves lead to accumulation of visceral fat, which is stored in the abdominal area, and this type of fat is particularly harmful to our health. The second or the indirect effect is such as altering our eating behavior. Stress can make us sensitive to food cues and increase our cravings, especially for unhealthy food like those which are high in fat and sugar. So, chronic stress uh, impacts in two ways: direct effect, indirect effect, both of which can increase the weight of an individual. Also, chronic stress also affects some important parts of the brain. For instance, the prefrontal cortex, which is responsible for decision making and self control, it becomes impaired during prolonged stress. And as a result, it becomes much harder to regulate eating behavior, making us more likely to overeat or make unhealthy food choices. Similarly, the reward system in the brain is also disrupted when we are in high stressful states for prolonged times, leading to heightened consumption of high fat and high sugar foods. Moreover, the stress response it interferes with appetite regulating hormones, which weakens our ability to recognize when we are full, thus increasing our desire for calorie dense foods. Also, stress often leads to sleep disruption. Poor sleep quality or insufficient sleep will make us hungrier and more fatigued, which in turn increases the likelihood of us turning to food for comfort. And this sets the stage for an unhealthy eating pattern to take hold. Not just presence of stress, but psychological traits they also play an important and significant role in emotional eating and weight gain. For example, Uh, for instance, people with neuroticism, which is a personality trait characterized by higher level of anxiety, impulsivity, emotional vulnerability, and anger, these people are at a greater risk of becoming overweight or obese. Those with higher neuroticism are often those with higher neuroticism. They often use food as coping strategy to deal with negative emotions. And emotional eating, that is eating in response to feelings like sadness, stress, or boredom, is common. And it often begins in childhood and it continues into adulthood. Over time, this becomes a learned behavior where food serves as a way to temporarily escape the emotional distress. And this pattern is strongly associated with a higher weight and higher BMI. It is also important to remember that not everyone responds to food cues in the same way, and some individuals are more sensitive to these cues, which makes it harder for them to resist cravings, to stay on healthier diets, and to control their eating. So, h- having said this, not all traits are towards making someone go towards obesity, but there are certain individuals who have protective traits as well. meaning that some people are better at regulating their internal urges, who possess self control, and are less likely to experience weight gain. These traits help individuals manage their eating habits and emotional responses more effectively. Another factor to consider uh, here is the food addiction. Now, food addiction, when we are saying, we are just drawing parallels with the substance use disorders. So, similar to substance use disorder, repeated exposure to highly palatable and calorie dense food, it can diminish our brain's dopamine response. That is, it makes it harder to feel satisfied with smaller portions, which leads to the need to eat more to achieve a feeling of satisfaction. As a person who would be, let's say, consuming a substance like nicotine, over time he will require more amount of nicotine to feel the same satisfaction. Same parallel can be drawn to food. A person who if we continue eating highly palatable and calorie dense foods, then it will be harder for us to feel satisfied with smaller portions, and thus it will lead us to need to eat more to achieve that feeling of satisfaction, which creates a cycle of overeating, and it contributes to weight gain. Now, with the above understanding, let's explore two types of eating behaviors. One is called the homeostatic eating, and the other is called the non-homeostatic eating. Homeostatic eating is when we eat to maintain the energy balance, which is regulated by our hormones like leptin and ghrelin, as discussed previously. So leptin signals us when we are full, and ghrelin signals our hunger, ensuring that we eat when it is needed to eat and to stop eating when we have had enough. So this system, the homeostatic system, it helps maintain the body weight and it prevents starvation. On the other hand, there is something called as non-homeostatic eating, which happens when we eat for reasons other than hunger, like emotional states or for pleasure. And this is driven by the brain's reward centers, which prioritize enjoyment over our energy needs. A common example of this, which we can relate to, is even after we are full, we want to go for a dessert, even if we know that we are not hungry anymore. So that comes under non-homeostatic eating. Extrapolating this concept of homeostatic and non-homeostatic eating, we can divide obesity into two types. One would be metabolic obesity, which occurs when the body defends a higher weight set point. That means that there is a set point of weight, and by homeostatic eating, we are supposed to maintain that set point. But in certain cases, the set point raises, so the body will have to defend a higher weight set point. And this often occurs due to leptin resistance in our body. The body resists weight loss and maintaining excess fat as a norm, even with calorie restriction. On the other hand, is the hedonic obesity, which is driven by the pleasure eating rather than the energy needs. And the brain's reward system makes certain foods irresistible for a person, leading to overeating even when a person is not hungry. So that is the difference between metabolic obesity and hedonic obesity. So as we bring all these pieces together, we start to view obesity not just as a physical condition, but as a psychosomatic illness, where the one where the mind and body, the functions are closely intertwined. So, as I said before, the if we are trying to fit obesity in a biopsychosocial model, it will help us understand that obesity isn't driven by any single factor. Instead, the psychological, the biological, and the environmental influences that we have discussed, they don't just exist side by side, but they are continuously interacting with each other. And this ongoing interaction is what shapes not only the development of obesity, but its persistence and progression over time. So as we look at this model, we see how our biological system, that is the hormones and energy regulation, they interact with the psychological factors like stress, emotional eating, and mental health, and together they influence how we eat, how our bodies store fat. And of course, all these are shaped by the environment, that is our access to the food, the societal pressures, and even our cultural attitude towards weight. So, biopsychosocial model is not just the only model who talks about interaction between the different aspects. There are other models called the ominous octet or the octagon of opportunities. They're different models given by different people, but the concept remains the same, that we cannot just consider obesity uh, just by just by the biological factors, and we need to include everything into it. And a more holistic approach is required. So now we will shift our focus to the psychiatric implications of obesity, or how we view obesity from the perspective of a mental health professional. So it is important to understand that significant mental health comorbidities, they are associated with obesity, as Sir was telling in the beginning of our session today. So obesity, it we can understand that it often coexists with various eating disorders like binge eating disorder or bulimia or night eating syndrome or graze eating syndrome. But it's not limited to just eating disorders. And as mentioned previously, when it comes to depression, uh, there is something very important that we need to understand. So one thing is that there is a notable overlap with obesity when it comes to depression, as both these conditions, they share some symptoms like increased appetite or low energy. And studies suggest that depression affects up to 66% of obese patients. And there are many factors that contribute to this link. The negative impact of health and body image, alongside increased functional impairment and social stigma, they often make it harder for an obese individual to maintain a positive mental state. What is interesting to note is that depression can also contribute to obesity in the form of elevated stress response, impaired immune system, negative eating behaviors. A person with depression will have a more sedentary life, will involve in overeating, and subsequently will have weight gain. So the relationship uh, between obesity and depression is a bidirectional one. Obesity can cause depression, or rather, obesity increases the risk of developing depression, and depression can increase the risk of developing obesity. Uh, this relationship, it is influenced by a lot of factors like the gender, the age, the socioeconomic status, with uh, females and individuals from lower income backgrounds, they being more vulnerable to both the conditions. So, coming to another important mental health concern, which is anxiety. Similar to depression, individuals with anxiety are more prone to develop obesity, and those with obesity are more prone to develop anxiety disorders. When we look at severe mental illnesses, which includes conditions such as schizophrenia or bipolar disorder, it is seen that there is an increased risk of obesity even in individuals who are suffering from severe mental illness. And up to 60% of the patients may be affected by obesity along with severe mental illness. One of the contributing factors is this use of psychotropic medications, which contribute to weight gain. And but even without medications, it has been seen in studies that some patients struggle with obesity. Uh, having if someone is suffering from severe mental illness, it puts them at a higher risk of metabolic diseases such as type 2 diabetes, cardiovascular disorders, and metabolic syndrome. So managing obesity in these patients, it becomes even more important and would involve regular monitoring of BMI, waist circumference, lipid profiles, their plasma glucose levels, and implementing lifestyle changes to mitigate the weight gain associated with the illness as well as with the medications. So, speaking of medications, there are certain psychotropic drugs, which includes antipsychotics, antidepressants, as well as mood stabilizers, which are linked with weight gain. And for instance, as I've shown, medications like olanzapine and quetiapine, they are known to contribute to significant weight gain. And this weight gain, it not only predisposes an individual to develop obesity and then subsequently its complications, but also a person who will be gaining weight when on medications, it will also affect the patient's adherence to the treatment. And as you can see, the weight gain can be, it's in cases of certain drugs, it can be very high, as olanzapine can cause up to 2 kg per month of weight gain when used regularly. And we also need to understand that mostly the patients are required to take these medications for long durations. So this side effect becomes an important side effect to be considered when starting patients on medications. And the side effect of weight gain is not limited to the antipsychotics. It is present with certain antidepressants and mood stabilizers as well. Now, there's also an important relationship between substance use disorders and obesity. Uh, we'll not go into details of all of them, but obesity or weight gain, it becomes important, especially for nicotine and alcohol use disorders. Both of them have a relationship, but it is slightly opposite. Nicotine dependence, in this sense, a person when they're trying to quit nicotine, when they are going through the withdrawals of nicotine, at that time they often tend to gain weight, and the fear of gaining weight sometimes it prevents them from stopping nicotine use. Similarly, people who are using alcohol or uh, suffering from alcohol use disorder, they are at increased risk for obesity due to the high calorie content of alcohol and its effect on metabolism. So, substance use disorder and obesity, they often coexist. They do share some biological mechanisms, and the treatment of both the disorders needs to be taken into account, needs to be done uh, simultaneously. Now, uh, we've l- heard about what are the psychiatric aspects of obesity. Apart from that, we all are obviously aware of the obesity related complications that can develop, physical complications that can develop, like coronary artery disease, stroke, sleep apnea, or many different types of cancers. So it becomes important for us even more to tackle obesity. What are the benefits of weight loss? So when we are when we are talking about benefits, we can divide the benefits into two aspects. One is there are physical benefits of weight loss. Uh, in the previous slide, we had seen what complications can occur because of obesity. So when a person suffering from obesity or living with obesity, if they try to reduce their weight, there are certain physical benefits, as in the risk for developing those complications, it will decrease. And studies have shown that a reduction of just 5 to 10% of body weight can lead to a substantial improvement in a person's blood pressure, lipid levels, and the overall metabolic risk. There are also studies who have shown uh, that have shown that even as low as a 3% reduction in body weight, or even a 1 kg of body weight, It has shown to decrease the mortality rates, particularly in individuals who are overweight or have other metabolic illnesses like diabetes. The benefits are not limited to the physical benefits. There are psychological benefits of weight loss as well. Achieving weight loss, even if modest, it has been consistently linked with improvement in body image, self esteem, and health related quality of life. Also, weight loss efforts often result in depression improvement, and individuals report feeling more positive about their health and appearance when they are losing weight. So, the key takeaway from the benefits of weight loss is that no goal is too small. Okay. When we are considering management of obesity, it is crucial to remember that small steps often lead to large, life changing benefits. So, how is obesity managed? We'll not go into too much detail of how management is done, but management is usually based on what the BMI level is of a person and what are the complications, what are the risk factor status. There are three basic approaches for management. First is the lifestyle management, second is the pharmacotherapy, the use of drugs, and third is the surgical interventions for obesity. So, coming to lifestyle management has three components. One is the diet therapy, the second is the exercise therapy, and third is the behavioral therapy. So, diet therapy, we know the primary goal is to reduce the overall calorie consumption. And there are various guidelines that describe how much calorie should be reduced, how much calorie deficit one should be experiencing on a daily basis to, and what should be the target of your weight loss. Other dietary therapy advice would include include smaller portions, to focus more on fruits, vegetables, and whole grains, lean meat, skimmed dairy products, to avoid having added fats, sugary beverages, etc. Similarly, when it comes to exercise therapy, there are various guidelines, such as the one that I've shown, that say that at least 150 minutes per week of moderate intensity aerobic activity or 75 minutes per week of vigorous intensity activity, they are sufficient to uh, for the weight loss process. But the focus today is more on the behavioral therapy, which is a part of the lifestyle management. It is sometimes it's called behavioral therapy, sometimes it's called behavioral weight loss or behavioral intervention, and it becomes a crucial component of obesity management. Now, what is behavioral therapy actually? Therapy, it is a structured intervention that focuses on modifying the unhealthy behavior, such as overeating or a sedentary lifestyle, by reinforcing healthier habits. So, this behavior therapy, it is based on learning theory, which suggests that behavior can be modified by altering environmental and psychological contexts. The key strategy in behavioral therapy include modifying the food intake, increasing physical activity, and controlling environmental cues and stimuli that may lead to overeating. The uh, treatment, it typically begins with weekly sessions, which are expected to continue for 4 to 6 months, followed by bi-weekly sessions during the weight maintenance phase. Mostly behavioral therapy needs to be done is better considered to be done as a group therapy, because group therapy has shown to be particularly effective with greater weight loss cost effectiveness when compared to individual care. Also, the group setting, it provides social support, it fosters empathy, and it even encourages healthy competition among individuals. Now, each session of behavioral therapy. It is expected to last around 1 to 1.5 hours, which involves private veins, that is confidential weighing your, of the patient, uh, progress reports, and then skill training in areas such as healthy food selection and portion control. On an average, it has the studies or research has shown that behavioral weight loss or behavioral therapy, it can lead to a 5 to 10% weight reduction over a 6 month period. It is also important to understand that the behavioral therapy cannot just be done by anyone. It needs specific professionals who have expertise in nutrition or psychology, who are required to provide this therapy. Second important intervention is what we call the cognitive behavioral therapy. Now, cognitive behavioral therapy for weight loss, it focuses not only on the behavioral aspects of eating and exercise, but it also addresses cognitive strategies and helps individuals identify and challenge the negative thought pattern that contributes to the unhealthy behavior. For example, if someone who has been making lifestyle modifications and has been on a diet control, so what happens is one day they'll have a cookie or something sweet, and just trying to just get a taste of it, and that one bite will turn into the whole cookie and it will turn into the whole package. And then they'll start thinking that uh, because of this, now all of their progress is gone into vain, and then they'll completely stop their whatever changes they had made and will go back to the previous level of diet. So CBT would involve challenging such beliefs and considering alternatives. It needs to be done by a trained psychologist, cannot be done just by anyone, and it includes techniques such as Socratic questioning, behavioral experiments, and additionally, people are patients living with obesity. They are taught about relaxation strategies such as guided imagery or diaphragmatic breathing, which are used to manage emotional distress, the distress that otherwise may trigger negative eating behavior. So the overall end goal for CBT for weight loss is to help patients to identify and challenge their dysfunctional thoughts, develop healthier thinking pattern, and manage stress effectively to support long-term behavioral change and weight management. Now, these two interventions that we discussed, the behavioral therapy and the cognitive behavioral therapy, they are the ones with more level of evidence, but there are other uh, psychological interventions that are also important when considering weight loss, which include the acceptance and commitment therapy, which targets the experiential avoidance. That is, it targets the tendency to avoid uncomfortable emotions, thoughts, or bodily sensations. Now, for many individuals with obesity, this avoidance can manifest as emotional eating or other unhealthy behavior, as we have discussed. Acceptance and commitment therapy, it aims to increase the patient's willingness to experience those negative emotions without resorting to avoidance behavior. It encourages patients to live in alignment with their values, prioritizing behaviors that promote the overall health and improve the quality of life. Key techniques that are included in the acceptance and commitment therapy include mindfulness practices, and etc., and other things. Apart from the acceptance and commitment therapy, then there is motivational interviewing, which works particularly well when used in conjunction with the trans theoretical model. Now, trans theoretical model of behavior change, it states that behavior change is a process and it is not a one-time event. There are stages through which a person goes when they're trying to make a change in their behavior, such as pre-contemplation phase, after which they move into contemplation phase, following which they go into the preparation, the action, the maintenance, and finally the termination phase. So, motivational interviewing, it addresses the patients who are in pre-contemplation or contemplation stage, and it tries to enhance their motivation to move through these stages, encouraging small manageable steps towards the action and maintenance phase. And this patient-centered approach, it empowers individuals to recognize their own reasons for change and build confidence in their ability to succeed. So I think I'll stop here, sir.
Thank you so much, Dr. Sarthak. A really comprehensive overview of obesity as a psychosomatic syndrome. एंड हमने रियलाइज किया होगा इतना सारा कुछ हमने सीखा और फिर और ज़्यादा क्वेश्चंस आ रहे हैं मन में. सो लॉट्स एंड लॉट्स ऑफ क्वेश्चंस फॉर यू डॉक्टर सार्थक एंड डॉक्टर एंड कॉम्प्लीमेंट्स एज वेल. एक एक करके सबको लेते हैं. जो रामजी अग्रवाल जी ने क्वेश्चन पूछा था शुरू में उसको एक्नॉलेज करते हैं एंड वी विल टेक इट टुवर्ड्स द एंड. एक
Hmm.
क्वेश्चन आ रहा है डॉक्टर सार्थक. दिस इज फ्रॉम धर्मेंद्र धवन जी. तो धवन साहब कहते हैं हैप्पी लोहड़ी. इनको शुगर भी है, फास्टिंग 350 रहती है. आई हैव पॉलीफेजिया. तो ये सवाल मैं लेता हूँ. पॉलीफेजिया मतलब भूख बहुत लगती है. ये शुगर का डायरेक्ट लक्षण है धर्मेंद्र जी. जब इतनी हाई ग्लूकोज होती है तो जैसे डॉक्टर सार्थक ने बात की, होम्योस्टैटिक ईटिंग और हीडोनिस्टिक ईटिंग की दोनों ही हैं इसमें. एक तो भूख लगती है, पहले कभी शौकीन होंगे खाने के तो आदत ही पड़ गई, दैट इज हीडोनिस्टिक, यू हैव गॉट यूज्ड टू इट. एंड अब बॉडी उसके बगैर रह नहीं पाती, इसलिए आप लिखते हैं आई हैव टू इनटेक मोर कार्बोहाइड्रेट्स टू रिमेन हेल्दी. सो डॉक्टर सार्थक को पूछते हैं, इफ somebody says I have to take more carbohydrates to remain healthy, and somebody says I have to take a little bit of opium in order to function, I cannot live without alcohol. What does this mean from a psychosomatic perspective?
So first of all, we need to uh, try and explore that what do they actually mean by that. What I'm trying to say is, at times, uh, especially when we are talking about substances, जैसे opium की बात की, alcohol की बात की, there are people who have been taking such things for long duration now. So their body has become has adapted to that. So there is a physical need for their body to have those substances. Second part would be the psychological aspects. So, whenever a person is saying that they cannot live with that, so we need to ask them whether it is because of physical factors that their body is adjusted to that, or is it because of psychological factors like craving, कि उसके बिना नहीं रह सकते. And then we need to, you know, target specific things what the person is talking about, and we need to reassure people कि whether it is physical symptoms or whether it is psychological symptoms, both can be tackled. They just need to be at the right place for that.
एंड धर्मेंद्र जी, बोथ विल बी देयर एक्चुअली. आप में साइकोलॉजिकल भी फिजिकल भी. ऐसे समझाने का तरीका है कि गन्ने से ही, शुगर केन से ही चीनी बनती है, गन्ने से ही शराब बनती है. तो जैसे किसी को आदत पड़ जाए शराब पीने की, लत लग जाए, वो छोड़ नहीं पाते. इट्स नॉट दैट दे आर सिक एंड दे कैन नॉट फंक्शन इन सोसाइटी, बट दे नीड टू गो एंड शो अ डॉक्टर, दे नीड टू शो अ साइकाइट्रिस्ट. सो अनकंट्रोल्ड अल्कोहल एडिक्शन इज सर्टनली अ प्रॉब्लम. बट यदि अगर आप उसको कंट्रोल कर लेते हैं, देन इट्स नॉट अ प्रॉब्लम एनी मोर. शर्त यह है कि यू रीच द राइट पर्सन. इसी तरह से अगर फास्टिंग ग्लूकोज हमारी 350 है और होनी चाहिए 100 से कम, तो ऑब्वियसली गड़बड़ है. सो व्हाट शुड आई डू का आंसर है, यू मस्ट शो अ डायबिटोलॉजिस्ट, यू मस्ट शो एन एंडोक्रिनोलॉजिस्ट, एंड वो आपकी ग्लूकोज डाउन लेके आएंगे धीरे धीरे और ये सारी चीजें ठीक हो जाएंगी. पर अगर एक चीज हम करें आज लोहड़ी के दिन धर्मेंद्र जी, तो अब जाके एंडोक्रिनोलॉजिस्ट को दिखाना है. इसमें कोई मर्दानगी नहीं है कि मैं 350 ग्लूकोज के साथ हूं और मैं फंक्शन कर रहा हूँ. इट कैन बी ट्रू फॉर अ शॉर्ट पीरियड ऑफ टाइम. मैं ठीक हूँ, मैं तंदुरुस्त हूँ, मुझे क्या हो सकता है शुगर से. बट इट विल नॉट बी ट्रू इन द लॉन्ग पीरियड, इन द लॉन्ग टर्म. तो कभी ना कभी दिक्कत आएगी. हम पहले ही एक्शन ले लें बिफोर प्रॉब्लम्स कम इन. अनवर साहब एक क्वेश्चन पूछते हैं. आपने डिस्क्राइब किया कि ओबेसिटी कैन बी व्यूड इन टर्म्स ऑफ साइकोसोमैटिक हेल्थ. साइकोलॉजिकल एस्पेक्ट्स भी हैं, फिजिकल भी हैं, दोनों इकट्ठे हैं. हाउ डू वी मेक अ पर्सन अंडरस्टैंड द रीजन फॉर ओबेसिटी? तो मैं बताता हूँ, मेरे पास मरीज आई ओबेसिटी की। हमें लगता है कि डिसऑर्डर्ड ईटिंग है, इमोशनल ईटिंग है, उसकी वजह से गड़बड़ हो रही है। हाउ डू वी मेक हर अंडरस्टैंड कि इट इज़ एन इमोशनल इशू, इट इज़ अ साइकोलॉजिकल इशू, एंड अंटिल दैट इज सॉर्टेड आउट, जो भी स्ट्रेस है घर पे, हमारी कोई भी दवा दारू असर नहीं करेगी। तो पेशेंट भी रेजिस्ट कर रही है और उसकी फैमिली भी रेजिस्ट कर रही है, एंड व्हाट दे वांट फ्रॉम मी इज अ लेबल ऑफ पॉलिसिस्टिक ओवरी सिंड्रोम, ताकि वो खुशी खुशी घर जाएं, जबकि एक्चुअली उस मरीज को पॉलिसिस्टिक ओवरी सिंड्रोम नहीं है। एक्चुअली इट इज एन इमोशनल डिसऑर्डर।
सो इस particular case में या in similar cases when a person is coming to us, so it is easier for what happens is it is easier for people to get a label of an illness कि ये बीमारी है, ये इसकी दवाई है, and then it becomes easier for them because अब उन्हें कुछ नहीं करना, अब दवाई को जो काम करना है वो करेगी. But scenarios can become very challenging in which you know that person is not in a stage in which the medication will help, or the conditions where medications cannot help until and unless there are steps taken by the person themselves. So उस केस में जैसे मैंने लास्ट में बताया कि change is not a one step process. मतलब it's not a one step thing. It's a process and there are different stages of change that one goes through. So कई बार होता है कि पेशेंट्स दे कम इन दी प्री कंटेम्पलेशन और कंटेम्पलेशन फेज कि हमारा अभी, और दे आर इन सॉर्ट ऑफ डिनाइल कि हमें अभी कुछ नहीं है, कोई दिक्कत नहीं, ये प्रॉब्लम नहीं है. सो इन दैट कंडीशंस वी नीड टू मेक देम गो थ्रू अ प्रोसेस जो मैंने बताया कि मोटिवेशनल इंटरव्यूइंग, जिसमें जो उनके एम्बिवेलेंसेस हैं, जो उनके डाउट्स हैं रिगार्डिंग कि ये प्रॉब्लम है या नहीं है, मेरा खाना प्रॉब्लम है या नहीं है, उसको वी हैव टू चैलेंज. We have to make them recognize and give them their own reasons for change, which will subsequently build confidence in their abilities, and gradually they will move from pre-contemplation to contemplation. Will they start thinking कि अच्छा ठीक है, हो सकता है कोई प्रॉब्लम है. नेक्स्ट स्टेप विल बी दैट they'll start प्रिपेयरिंग कि वो प्लान करेंगे, अच्छा ठीक है मैं अब एक साइकोलॉजिस्ट के पास या न्यूट्रिशनिस्ट के पास जा सकता हूँ. देन they'll start going there, then they'll go into the active stage. So we need to see where the person is in this chain of behavior change, and उस हिसाब से we'll have to intervene.
बिल्कुल सही कहा। तो एक तो इफ समबडी हैज़ बीन लिविंग विद ओबेसिटी लेट अस से फॉर 5, 10, 15 इयर्स, तो यू कैन नॉट एक्सपेक्ट कि 5, 10, 15 मिनट्स में सारा चेंज आ जाएगा। तो वो हमें अपनी एक्सपेक्टेशन रियलिटी के साथ टेम्पर करनी पड़ेंगी।
Yes.
तो एक तो एक्नॉलेज करें, यस आई अंडरस्टैंड, एंड नो नो नीड टू फाइट डायरेक्टली। आपको पीसीओएस नहीं है, वी व्हाट डू यू गेन बाय दैट? वी माइट से समथिंग लाइक हाँ जी पीसीओएस हो सकता है, इट कैन बी कंट्रीब्यूटर, इट कैन बी अ कंफाउंडर। हो सकता है आपका पीसीओएस कच्चा पीसीओएस है, यदि हम अपनी डाइट पे ख्याल रखें तो हम अपनी ओवरीज को जड़ से ठीक कर सकते हैं। नाउ सडनली यू हैव क्रिएटेड एन एलिमेंट ऑफ ऑप्टिमिज्म, आपकी बीमारी जड़ से निकल सकती है। You've also put the onus on that person, and you've given that reality check, यदि हम अपने डाइट का ख्याल रखें तो, so that caveat is there. And then once you've acknowledged, once you've appreciated, and you've not argued with the patient, then that ambivalence which Dr. Sarthak spoke about, हाँ जी मैं डाइट में वाकई सही हूँ या नहीं हूँ, चलो लेट्स टॉक अबाउट इट। घी मक्खन मलाई तो नहीं खाते ना जी, मैं तो बिल्कुल नहीं खाती। यस आई अंडरस्टैंड आप घी मक्खन मलाई नहीं खाते, दैट इज द विजिबल घी मक्खन मलाई, द विजिबल फैट्स, द विजिबल शुगर। बट आपको पता है आजकल हमारी डाइट में छुपा हुआ घी बहुत है। फॉर एग्जाम्पल आपने कोई तला हुआ नमकीन खाया, वो हमें दिखाई नहीं देता कि तला हुआ है, या पोटैटो चिप्स हैं पर उनमें घी बहुत होता है। सो देन नाउ यू टोल्ड द पेशेंट आई एम नॉट ब्लेमिंग यू, इट्स छुपा हुआ घी। Let's learn how to find out छुपा हुआ घी मक्खन मलाई in all our processed foods. Let's learn how to find छुपी हुई calories. So now you are friends now, and both of you are fighting against that those छुपा हुआ dinosaurs and dragons जो हमारे पोटैटो चिप्स के पैकेट्स में हैं और बाकी नमकीन में है, मिठाई में है। Once you've done that, then you just add one thought at a time. Yeah, I think I can stop ghee makhan malai. I think I can stop potato chips. I can also stop mithai. And then the patient will come and say, can I stop fruit also? Should I stop fruit? The answer is nahi, aap fruit kha sakti hain. So it's one step at a time. And like we said, action is going to be stepwise. If someone has been living with obesity for so long, That action will also happen over a period of time. रेखा जी, अजय कुमार जी आपको गुड इवनिंग कर रहे हैं सर. दीपक राज जी बोलते हैं मैं डॉक्टर के अग्रवाल को याद करता हूँ एंड सर हैज बीन अ ग्रेट बीकन ऑफ इंस्पिरेशन फॉर अस. विनायक शर्मा जी की तरफ से आपको एक हैप्पी लोहड़ी है. एंड प्रदीप रावल, डॉक्टर प्रदीप रावल फ्रॉम उज्जैन says hi to you. Couple of more questions, and this is a very tough question from Dr. Mukesh Makrolia. He says, sir, in obese men, we see feminization. That is true, because एक एंजाइम होता है एरोमेटेज इन एडिपोज टिश्यू. तो एरोमेटेज जो है हमारे टेस्टोस्टेरोन को इन मेन उसको तोड़ के फीमेल हार्मोन ईस्ट्रोजन बनाता है. सो द मोर ओबीज यू आर, the more adipose tissue you will have, the more aromatase there will be, and that aromatase will convert testosterone into female hormones. So you see a level of feminization. इसके अलावा एक डिजीज है हाइपोगोनेडोट्रोपिक हाइपोगोनेडिज्म. इसमें ब्रेन पिट्यूटरी ग्लैंड काम नहीं करता. तो हाइपोगोनेडिज्म मतलब मेल गोनेडल हार्मोन्स कम है. एंड दिस ऑल्सो प्रेजेंट्स विद अ काइंड ऑफ फेमिनिन काइंड ऑफ अ लुक. लंबे गोरे पतले लड़के होंगे बट दे विल बी अ टमी. सेंट्रल ओबेसिटी जरूर होगी उनकी. Dr. Mikesh also points out that in obese women, virilization is noted. And that is also true because testosterone occurs in women as well. Uh, पुरुषों में भी होता है, विमेन में भी होता है. और ओवरी के अंदर अगर टेस्टोस्टेरोन का लेवल बढ़ जाए या टेस्टोस्टेरोन की एक्शन बढ़ जाए तो दैट कॉजेज विरलाइजेशन. सो देन यू सी दीज सिम्टम्स एंड साइंस ऑफ पॉलिसिस्टिक ओवरी सिंड्रोम. और ये ओबेसिटी में बढ़ते हैं. ओबेसिटी में जैसे इंसुलिन रेजिस्टेंस होती है, इंसुलिन रेजिस्टेंस की वजह से टेस्टोस्टेरोन एक्शन बढ़ जाता है ओवरी में. सो वी सी both ends of the spectrum are there, and that does trigger psychosomatic disorder. So question for Dr. Kukreja is, यदि कोई पुरुष आते हैं with symptoms of feminization or with sexual dysfunction, issues regarding self esteem, या कोई महिला आती हैं, लेडी आती हैं with virilization, how do we handle such patients apart from whatever biomedical therapy is to be given to them?
I think most important thing would be good communication. If a person comes to you, then if a patient comes with either of these spectrum of problems with the doctor, then the doctor needs to explain them why this is happening to them and what is the reason behind them. जैसे अभी आपने सर एक्सप्लेन किया कि दो स्पेक्ट्रम में दोनों पॉसिबल है. विरलाइजेशन इन फीमेल्स हो सकता है, सिमिलरली फेमिनाइजेशन इन मेन हो सकता है. सो आई बिलीव इज when a person can understand that what is happening with them, why is that happening, I think आधी एंजाइटी तो उसी से कम हो जाती है. And then we need to reassure them that whatever changes are happening, these are reversible, these are treatable. Some effort will be required by the medications, some effort by the patient themselves. So I think when if a patient can understand कि उनके साथ क्या हो रहा है, क्यों हो रहा है और आगे क्या होगा, तो I think more than 50% of the anxiety will reduce. Yes, जो visible factors हैं, मतलब if a female has undergone virilizing features उसमें हैं, there might be factors जो social stigma and other things होती हैं, they might play a role there. So we need to see कि वो जो उस thought process की वजह से dysfunction हो रहा है, वो कितने level पे dysfunction हो रहा है. एंड मेजोरिटी ऑफ द टाइम्स आई बिलीव दैट उस डिस्फंक्शन के लिए अलग से ट्रीटमेंट की जरूरत नहीं पड़ती. जस्ट अ गुड therapeutic relationship between the patient and a treating physician, I think that is more than enough.
तो जो डॉक्टर कुकरेजा कह रहे हैं, यदि ऐसा कोई मरीज आए और ऐसे बहुत लोग हैं आसपास, सो इफ आर एक्नॉलेज देयर कंसर्न्स, देयर कंप्लेंट्स, देयर चैलेंजेस, एक्नॉलेज ऑल्सो. आई माइट से, बेटे आई अंडरस्टैंड, मुझे तो तुम बहुत प्यारी लग रही हो, आपके पापा और मुझे यू आर द मोस्ट ब्यूटीफुल गर्ल इन द वर्ल्ड, बट वी एक्नॉलेज, वी अंडरस्टैंड दैट यू आर फेसिंग चैलेंजेस एट स्कूल और इन कॉलेज, और इफ यू आर ऑफ मैरिजेबल एज वी अंडरस्टैंड दैट देयर आर चैलेंजेस. तभी तो मम्मी पापा लेके आए हैं आपको. इफ दे डिडंट अंडरस्टैंड, व्हाई वुड दे ब्रिंग यू? बट this is an explanation, this is the scientific explanation. Hormones का imbalance है, that is easy to explain actually. Hormones बदलते हैं in an obese ovary or in obese adipose tissue, but we do have interventions available. So explanation, and these are the interventions that are available, and then you divide the responsibility. कुछ एक चीज़ें आपकी हैं, लाइक सेल्फ मैनेजमेंट, सेल्फ केयर, सेल्फ बिहेवियर यू हैव टू डू। द मेडिकेशन वी विल टेक केयर, वातावरण ठीक रखेंगे, एंड एन ऑप्टिमिस्टिक आउटकम, कि दिस इज रियलिस्टिक आउटकम ऑल्सो, दिस इज अ realistic outcome that we can hope for in the next couple of months. If you do that, then problems get solved out. Sometimes mismanagement बहुत होती है, like an obese person coming with low testosterone. Now the treatment is to reduce body weight in 90% of all such men. But testosterone दिया जाता है, टेस्टोस्टेरोन से और वेट बढ़ता है और एडिपोज टिश्यू बढ़ता है, और फाइनली स्पीड चाहे आपको ठीक दिखाई दे 5-10 दिन के लिए, वेलोसिटी जहां तक है, patient comes back to you in a much unhappier mood after 6 months or 1 year, because that adiposity has increased, या gynecomastia has increased because of unwanted testosterone. स्वप्ना जैन मैडम इसको बहुत नाइस वे में समराइज कर रही हैं, डॉक्टर सार्थक, आपकी टॉक को. अपार्ट फ्रॉम द साइकोसोमैटिक एस्पेक्ट्स ऑफ ओबेसिटी, शी कॉल्स इट कॉस्मिक और मेटाफिजिकल डिजीज. सो मेटाफिजिक्स मतलब, मेटा मतलब परे, फिजिक्स से परे. सो सम थिंग्स वी कैन एक्सप्लेन बेस्ड अपॉन बायोलॉजी, बेस्ड अपॉन फिजिक्स, ऑन केमिस्ट्री. तो यदि ऐसा होता तो ओबेसिटी का सिर्फ होता भी एनर्जी इनटेक कितना है, एनर्जी एक्सपेंडिचर कितना है, एक सिंपल सी इक्वेशन बनती, हम बता देते जी इतना वेट है. But so many people living with obesity, they say it's not like that. I am actually taking only 1200 calories a day. I'm burning 1400, still I'm not losing weight. That means physics is not adequate in explaining obesity. यदि ऐसा है, then you need metaphysics, which means physics से परे. एंड स्वप्ना जैन मैडम ने इसको बहुत नाइस वे में किया है. शी हैज टेकन द एग्जांपल ऑफ कॉस्मिक एनर्जी टू एक्सप्लेन द पैथोफिजियोलॉजी एंड प्रेजेंटेशन ऑफ ओबेसिटी. सो फ्रॉम कॉस्मिक शी हैज गॉट सी फॉर कॉग्निटिव फैक्टर्स. आपकी सोच कैसी है, उससे आपके वेट पे इम्पैक्ट आता है. यदि आप पॉजिटिव सोचेंगे तो आपको पॉजिटिव आउटकम मिलेंगे. ओ इज फॉर ओबेसिटी जीन्स, आप ऑफस्प्रिंग किसके हैं, उसके साथ तो हम लड़ झगड़ नहीं सकते. बट जेनेटिक्स के अलावा एक और चीज है एपीजेनेटिक्स आजकल. सो डॉक्टर सार्थक, एपीजेनेटिक्स, इज दिस अ कॉमनली यूज्ड टर्म इन साइकाइट्री, एंड व्हाट डज इट मीन टू अ साइकाइट्रिस्ट फ्रॉम अ साइकाइट्री हेल्थ पर्सपेक्टिव?
It's not very commonly used when we talk about patient care, but yes, from a research perspective, there is a lot of exploration going on into the genes as well as the epigenetic factors. For instance, जैसे मैंने एक जो टेबल दिखाई थी regarding the genetic mutations that are associated with obesity, one of the genes mutated in that was BDNF, brain-derived neurotropic factors. So BDNF, for example, is associated with obesity as well as it has a strong link with psychiatric illnesses as well.
एंड मेटाबॉलिक मेडिसिन में एपिजेनेटिक्स की बात अब बार बार हो रही है. जीन्स तो हुए जो हमें अपने पेरेंट्स से मिले विरासत में. एपिजेनेटिक्स है, जीन वही है, मगर उस पे मान लो चर्बी की परत लग गई आपके जीन के ऊपर, मिथाइलेशन हो गया आपके डीएनए का, तो ऑब्वियसली उसका स्ट्रक्चर भी बदलेगा और उसका फंक्शन भी बदलेगा. मेरे पास सबसे बढ़िया कार है, दैट इज जेनेटिक. मैंने इंजन बढ़िया खरीदा बीएमडब्ल्यू से या मर्सिडीज से, पर उसका मैं ख्याल ना रखूं और मेरे इंजन के ऊपर धूल मिट्टी की परत लग जाए, एक दिन दो दिन कोई फर्क नहीं पड़ेगा. कार्बन जम जाए हमारे इंजन में, एक दिन दो दिन फर्क नहीं पड़ेगा. पर अगर मैं उसका बिल्कुल भी ख्याल ना रखूं अपनी गाड़ी का, तो ऑब्वियसली इतना गंद लग जाएगा उस इंजन पे, इतना कार्बन जम जाएगा कि वो इंजन ही नहीं चलेगा. दिस इज एपिजेनेटिक्स. सो यू कैन बाय द बेस्ट मशीन इन द वर्ल्ड, बट इफ यू डोंट टेक केयर ऑफ इट, इट्स नॉट गोइंग टू फंक्शन. और एक दिन की बात नहीं है कि वो कार्बन या धूल मिट्टी एक दिन में जमी, एक सर्दी में, एक साल में, 2 4 6 साल में गड़बड़ होगी, एंड मल्टीपल फैक्टर्स देन. सो दैट इज एपिजेनेटिक्स. एंड एपिजेनेटिक्स पे हम काबू कर सकते हैं अगर हम अपने जीन्स का, हम अपनी गाड़ी की, अपनी बॉडी की मशीन का ख्याल रखें, उस पर धूल मिट्टी ना जमने दें, मिथाइलेशन ना होने दें अपने डीएनए का, चर्बी ना जमने दें अपने जीन्स पे, then obviously we can improve our health. And this is that concept of transgenerational karma, transgenerational metabolic health. यदि मदर प्रेगनेंसी से पहले, प्रेगनेंसी के दौरान और प्रेगनेंसी के बाद बॉडी, बेबी को जब बेबी फीड करते हैं बेबी को, उस समय पे अपना ख्याल रखें अपनी सेहत का. अपनी सेहत तो ठीक होती होती है, आने वाली नस्ल, आने वाला बच्चा जो है वो भी ज्यादा हेल्दी हेल्दी पैदा होता है, मेटाबॉलिक सिंड्रोम नहीं होता. एंड इवन फ्रॉम अ साइकेट्री पर्सपेक्टिव, ऑटिज्म अब बहुत बढ़ता जा रहा है. हम जब स्टूडेंट्स थे, आई यूज्ड टू सी, मे बी कभी गलती से गए पीड्स में, साइकेट्री में, तो एक मरीज दिख गया साल में. Now it is a term that is used every day, left, right, center. ADHD is a term that is used. It is over and wrongly diagnosed also many times. But these are also part of that epigenetic phenomena. Uh, so O से हो गया offspring या obesity genes and C was for cognitive factors आपकी सोच. S से स्वप्ना जैन मैडम कहती हैं stress response. So how you respond to stress? Emotional eating, hedonistic eating. एम से मेटाबॉलिक डिसरेगुलेशन. ऑब्वियसली अगर वेट है, मोटापा है, तो आपको ब्लड प्रेशर का, शुगर का, कोलेस्ट्रॉल का भी ख्याल रखना है. आई इज फॉर इन्फ्लेमेशन. एंड दैट इज वेरी ट्रू सपना जी, बिकॉज ओबेसिटी इज अ लो ग्रेड इन्फ्लेमेटरी डिजीज. इट इज एक्चुअली एन इन्फ्लेमेटरी रिस्पॉन्स. तो कुछ एक हमारे टेस्ट हैं, जैसे HSCRP है, CRP, वो ओबेसिटी में वैसे ही बड़ा होता है. एंड सी से कॉस्मिक से स्वप्ना जैन जी मैडम कंक्लूड करती हैं, जैसे हमने कहा मेटाफिजिकल, दैट मीन्स फिजिक्स से परे, तो ऐसी वेट से परे अदर chronic diseases, and Dr. Sarthik has mentioned so many of them, like anxiety, depression, substance abuse, schizophrenia. All these diseases also can coexist with, and they can contribute to, and they can confuse the management of obesity. So thank you Sapna madam for this wonderful idea of cosmic. And इससे डॉक्टर सार्थक, जब आप ऐसे चीजें हम सुनते हैं, सीखते हैं अपने व्यूअर से, ऑडियंस से, डज इट गिव यू अ काइंड ऑफ कॉस्मिक एनर्जी?
It does, it does.
It actually does. And same thing that Sachin Bhatia Saab, who's an industry leader from Haryana, is saying. So actually cosmic energy आती है when you speak with each other, when you learn from each other. इट्स ऑलरेडी 10 past 8, बट एक क्वेश्चन हमने प्रॉमिस किया था कि हम लेंगे राम जी अग्रवाल साहब का, ये मैं लेता हूँ. हाल ही में व्हाट्सएप पे खूब सारे वीडियोस हैं जो कह रहे हैं कि डायबिटीज के डायग्नोसिस का तरीका बदल गया है. ये बिल्कुल बिल्कुल गलत है, सरासर गलत है. दो डायग्नोस्टिक क्राइटेरिया हैं वर्ल्ड में डायबिटीज के, एक वर्ल्ड हेल्थ ऑर्गेनाइजेशन का और एक अमेरिकन डायबिटीज एसोसिएशन का. यदि कोई ये कहता है कि अमेरिकन कॉलेज ऑफ फिजिशियंस, जो एक कॉलेज है, वो WHO से बड़ा है, तो बिल्कुल गलत है. बिल्कुल गलत है, मतलब मानने लायक ही नहीं है. WHO के और ADA के सेम डायग्नोस्टिक क्राइटेरिया हैं डायबिटीज के, और पिछले 30 साल से नहीं बदले हैं ये. फास्टिंग ग्लूकोज 126 के ऊपर, रैंडम या पोस्ट लोड 200 के ऊपर, ये डायबिटीज है. एक प्री डायबिटीज में जरूर कंफ्यूजन है. WHO कहता है कि फास्टिंग 110 के ऊपर हम प्री डायबिटीज डायग्नोज करेंगे, 110 से 126, और ADA कहता है 100 से लेके 126. तो उतना अंतर है दोनों में प्री डायबिटीज में, बाकी बिल्कुल कोई फर्क नहीं है. और जो है कट ऑफ फॉर ट्रीटमेंट, वो वेरी करेगा फ्रॉम पर्सन टू पर्सन. तो जो वो व्हाट्सएप में जो भाई साहब कहते हैं, बिल्कुल गलत कहते हैं, मगर ये सही है कि हर व्यक्ति के लिए थ्रेशोल्ड फॉर इंटरवेंशन विल बी डिफरेंट. किसी में हम बहुत जल्दी इंटरवीन करेंगे, कोई 25 साल की लड़की अभी फैमिली प्लान करनी है. किसी में हम लेट इंटरवीन करेंगे, 85 साल के बुजुर्ग हैं, उनको वैसे ही इतनी सारी दिक्कतें हैं, कैंसर है, और चीजें हैं, तो यू आर वरीड अबाउट दैट, यू मे नॉट इंटरवीन फॉर डायबिटीज. थ्रेशोल्ड फॉर फार्माकोलॉजिकल इंटरवेंशन, दवाई कब देंगे, that will also differ. The younger the patient, the earlier you will intervene and the more aggressively you will intervene. The older the patient, you may not intervene so fast. यंगर पेशेंट्स में बल्कि एक कॉन्सेप्ट है हिट अर्ली हिट हार्ड, यह है मेटाबॉलिक मेमोरी का. यदि हम जल्दी शुगर कंट्रोल करते हैं, तो शुगर कहीं पे भी नहीं जमती शरीर में, ना ब्रेन में, ना शरीर के बाकी अंगों में. तो ये आपका ब्रेन और आपके शरीर के सारे अंग बाद में भी तंदुरुस्त रहेंगे. दे विल एंजॉय अ गुड मेटाबॉलिक मेमोरी, दे विल हैव गुड मेटाबॉलिक कर्मा. और फिर है टारगेट थ्रेशोल्ड, आप कितनी ग्लूकोज कम लाना चाहते हैं. यहाँ पे जरूर है कि किसी में हो सकता है आप 200 शुगर के साथ बहुत हैप्पी फील करें, किसी में 250 के साथ भी फील करें, किसी में 125 के साथ. दिस डिसीजन इज बेस्ड अपॉन बायोमेडिकल एंड साइकोलॉजिकल फैक्टर्स. इट शुड बी डन एज अ पार्ट ऑफ शेयर्ड डिसीजन मेकिंग विद योर एंडोक्रिनोलॉजिस्ट. तो फिर से कहूंगा, जो लोग इस तरह की गलत चीजें फैलाते हैं, वो क्यों फैलाते हैं वो वही जाने, या भगवान जाने या वो जाने, पर बिल्कुल गलत है. द डायग्नोस्टिक क्राइटेरिया हैव बीन द सेम, विल रिमेन द सेम इन द नियर फ्यूचर, and the thresholds for intervention and target, they vary from person to person. So that will be decided by the patient, the family and the doctor together. We've had a great day today, Dr. Sarthak. Thank you so much. हमारे साथ श्रियन भी हैं backstage. So Shriyan, have you been listening for the past now how many minutes? 73 minutes. What did anything new that you learned from Dr. Kukreja?
Yes, sir. From today's session, what I understood is how obesity as in psychosomatic syndrome, emphasizing its interplay between psychological and physical factor. And also from today's session, also underscore how stress, emotion, and mental health contribution over overeating and weight gain alongside with the biological factor. So this is what I have understood from today's session, sir. It's been really a wonderful session from Dr. Sarthak, and I would like to thank him for that. Thank you, sir.
Thank you. And can we show him a certificate of appreciation, please? थैंक यू सो मच डॉक्टर सार्थक। अग्रवाल जी को भी थैंक यू बोलूँगा एंड तक रुकने के लिए, बिकॉज़ आपका सबसे पहले वाला स्वाद और हमने लिया सबसे आखिर में। चीज़ें ऐसे इतनी सारी होती हैं, ऑल ऑफ अस वांट स्ट्रेट फॉरवर्ड आंसर्स, ब्लैक एंड व्हाइट, बट ज़्यादातर ब्लैक एंड व्हाइट आंसर्स नहीं होते। इफ्स एंड बट्स, किंतु परंतु बहुत होता है। और खासकर ओबेसिटी और डायबिटीज़ में जो इतने मल्टी फैक्टोरियल, मल्टी फैसेटेड डिजीज़ेज़ हैं, इतने सारे पहलू हैं इन बीमारियों के। एंड डॉक्टर सार्थक हैज़ हेल्प्ड अस सिंप्लीफाई सो मेनी थिंग्स। बट डॉक्टर सार्थक, वी हैव मोर एंड मोर क्वेश्चंस नाउ फॉर यू इसके बाद। सो एक हमारी तरफ से सवाल है, विल यू बी हैप्पी कमिंग बैक ऑन केके मेड टॉक्स टू आंसर मोर क्वेश्चंस फॉर अस?
Sure, sir.
थैंक यू। राम जी साहब ने सोशल मीडिया से लिया, हमने भी सुना अग्रवाल साहब, और अब कैसे जवाब दें उसका वो भी कभी-कभी समझ नहीं आता। बट केके मेड टॉक्स इज़ अ वेरी गुड मीडिया जहाँ पे हमारे पास एक्सपर्ट्स आते हैं लाइक डॉक्टर कुकरेजा, एंड वी ऑलरेडी सेड ही इज़ द स्पेशलिस्ट फॉर साइकोसोमैटिक मेडिसिन, एंड दे हेल्प अस गेट द राइट आंसर्स। मेनी टाइम्स वी हैव मोर क्वेश्चंस, तो हम और सवाल पूछेंगे एंड फिर डॉक्टर कुकरेजा से फिर मिलते रहेंगे। इसके साथ डॉक्टर सार्थक को शुक्रिया, धन्यवाद, मेहरबानी। थारा भला हो डॉक्टर सार्थक,
Thank you,
एंड
sir.
जय हिंद। जय हिंद।